In this talk, we're going to go over the daily checklist that should be performed on all ITU patients and discuss the different components and why it's important. We like care bundles. So care bundles are a group of between sort of 3 and 5, sometimes more actually, evidence-based interventions which, when you do them together, have a better outcome than if you do them individually. And although each intervention on its own may seem very minor, it should be widely accepted as good practice. And we should aim to do this for every patient 100% of the time. And we can measure our adherence to these care bundles as a way of auditing good practice. So our daily checklist you will see on the bottom of our ward round entry, and a lot of it's based on the work of Jean-Louis Vincent in coming up with his fast hug approach, where he considered what kind of bundles and care package we should put together to review every day in patients that are critically ill. And in particular, he highlighted feeding. So can we feed them orally? If not, should we start parenteral feeding? Analgesia, so we need to pay close attention to make sure they're not suffering pain, but that we're not overdoing it. Sedation, so a patient should be calm, comfortable, and collaborative, i.e. they're able to engage with us. And again, on the topic of sedation, should we do a sedation break? We should aim to do those every day in patients where it's safe to do so. Thromboembolic prevention, so every patient should have VT prophylaxis unless there's a specific reason not to. Head of the bed elevation, so between 30 and 45 degrees is optimal, and this can help reduce the risk of ventilator-associated pneumonia. Stress ulcer prophylaxis, so on our unit we use proton pump inhibitors, and then glucose control. So we don't do tight glycemic control anymore. A BM target between 6 and 10 is perfectly fine. So the F in fast hug stands for feeding. So all patients should be fed, if at all possible. The best form of maintenance fluid is enteral feed, so we're always very keen to get that started as soon as possible. The route this happens through, the best way is the patient's awake and eating. That may not be, often isn't feasible in our patients, so a nasogastric tube to allow enteral feed. We need to check that it's being absorbed, so we measure gastric residual volumes, and a high volume, how you define high volume is up for debate, but in a non-surgical abdomen, certainly over sort of 400 ml residual volume would make you think maybe this patient is absorbing. And then bowels, so they need to open their bowels, and we have a bowel protocol we follow. Every patient should be on Senna and Docusate, and then if they haven't opened their bowels at 48 hours, we tend to add Movicol, and then the next day, if they still haven't opened their bowels, we would tend to do a PR and give some suppositories at that point. In terms of TPN, it does feel a very sort of critical care type thing to do, to feed people intravenously, but actually there's no evidence that early parenteral nutrition improves outcomes. So we don't tend to start it early, and by that I mean in less than a week after admission. The A stands for analgesia, so it's important that patients aren't suffering and aren't in pain. So we tend to give regular paracetamol and an opiate infusion for those that are sedated for analgesia. Those with particularly complex pain requirements may have other adjuncts like pregabalin, gabapentin, ketamine, that sort of thing. But it's worth pointing out that treating a fever with regular paracetamol doesn't seem to improve outcomes. However, it does make the patient feel better, so it's not necessarily a bad thing. S is for sedation, so we should have a sedation target, and we would use the RASS score, or the Richmond Agitation and Sedation Score, ideally a target of 0 to -2 to allow the patient to be calm, cooperative, and comfortable. And it's very important that we stop this sedation every day, if safe to do so. And this isn't always to try and extubate the patient. Often it's just a period of wakening to assess the neurology and see if there's any delirium treatment that's required underneath the sedation. Because if you're stopping sedation every day, the total dose of sedation the patient's receiving over a period of days will be less, and that's got to be a good thing. And there is some evidence for this, that a daily paired sedation break with ventilatory weaning or spontaneous breathing trial resulted in better outcomes with shorter times on the ventilator. Following on from sedation is delirium, so it's important to monitor for this, and we would use the CAM-ICU score, which the nurses can do at the bedside. And a CAM-ICU positive patient means they are scoring for delirium. And this is an example of the CAM-ICU test. So it measures inattention and disorganised thinking. And if CAM-ICU is positive, that means you've diagnosed delirium. In terms of management delirium, well, the simple things are important. So establishing a proper sleep routine, keeping the patient's bed space quiet at night time and dark, offering iPads and earplugs, reorientating themselves with access to a clock, visits from family, that sort of thing. But there is obviously pharmacological treatment. There's no evidence that treating with antipsychotics, for example, shortens the duration of delirium, but occasionally it's necessary to do so to maintain the patient's safety. So often we'd use quetiapine in the first instance. Thromboembolic prophylaxis is very important. All patients should be on it unless there's a contraindication. And this is national guidance that all patients need to be assessed for the risk of VTE and thromboprophylaxis be prescribed. If they can't have VTE prophylaxis, for example, they've got an intracranial hemorrhage, for example, they need mechanical prophylaxis, and we would use the Flowtron boots. Head-up positioning. So we know that leaving a patient flat on a ventilator increases the risk of ventilator-associated pneumonia. And when we talk about marginal gains, the patient may not die of this pneumonia. We will spot it and we will treat it, but it will almost certainly prolong the ventilation and lead to increased muscle mass loss and worse functional outcomes. So it's important that we keep these patients head up unless there's a reason we can't, for example, spinal injury. Also prophylaxis, so we would use a PPI, either lansoprazole if they can have enteral treatment, or pantoprazole if they require intravenous. And patients that we would class as at risk of stress ulceration would be patients who are ventilated, patients who have no enteral intake, patients on anticoagulation or antiplatelets, or patients on steroids. And in general, patients will always be on a PPI whilst very sick on ITU, unless there's a particular reason not to. And when they start to improve, that's when we'll start to review to stop it. Glucose. So it used to be the case that there would be tight glycemic control based on a variety of papers back in the day, as it were. But increasingly the feeling is, and the evidence shows, that all tight glycemic control does is increases the risk of hypoglycemia without improving outcomes. So we tend to be a bit more relaxed, and certainly we would just try and keep the glucose less than 10. Speaking of care bundles, there is a well-founded care bundle around the insertion of central lines, and this is based on some work done in Michigan where they managed to introduce a large and sustained reduction of up to 66% in catheter-related bloodstream infections by following some very simple interventions. And this is very simple things like ensuring that you have hand hygiene, wear a gown, gloves, hat and mask, that the skin is properly cleaned using chlorhexidine, and that you use maximal sterile precautions such as full barrier drapes, and that where possible you avoid the femoral root. And again, central line maintenance is important, so using an aseptic access technique, reviewing the site daily and removing the lines as early as possible when they're no longer needed. And so all these steps and this care bundle forms part of our LOCSIPs when we're inserting the line to ensure maximum sterility to reduce the risk of catheter-related bloodstream infection. In terms of oral care when the patient is ventilated, there's been a variety of different methods over the years. What we tend to do at the moment is oral care with simple lollipops soaked in water to clean debris, and a chlorhexidine mouthwash to clean the mouth. And this is supposed to reduce the risk of colonisation and ventilator-associated pneumonia. But whilst checking this every day, all these things every day is important. It's important to note any deterioration. And there's lots of evidence out there that delays to treatment for anything leads to worse outcomes. And the sort of seminal paper on this in septic shock was from Anand Kumar, who showed an almost linear relationship in length of time from onset of hypertension to length of time when antibiotics were given. And the quicker the antibiotics were given, the better the patient did. So any deterioration needs to be seen quickly and managed rapidly. So this is the checklist again that we would do every day. So we're going to check, is the patient 30 to 40 degrees head up? Is the oxygen they're receiving humidified? Are they having oral care? Have we assessed their pressure area integrity? Have we reviewed their sleep? Are they due a sedation break today? Have they got delirium using CAM-ICU? Have we reviewed their lines and the duration they've been in and whether they're still needed? Have we reviewed their prescription chart and any drugs that are or aren't required? Are they a VTE risk? So the answer to this will always be yes. And are they a bleeding risk? So for example, do they have active hemorrhage or do they have a bleeding in a critical area such as in the brain? And then are we giving VTE prophylaxis or therapeutic anticoagulation? Have we reviewed the antibiotics they're on and whether they're indicated? Are they being fed and how? Do they require gastroprophylaxis and do they require glucose control? And then there's a box at the bottom to review when they last opened their bowels and when we last updated the family. So by reviewing this checklist every day, we're ensuring that we're following all of these things that we've just discussed in this talk.